hello, doctors. Hope you're all doing well. I'm very glad for us to meet today and to study. And very glad to join you from Saskatchewan as usual. So please let me know where you're joining me from. Okay, let me know where you're joining me from and how is the weather treating you. How is the weather treating you? So I'm very happy about today's class. Today's class is going to be straightforward and very, focused on various things. But people were asking me, so Dr. Bruni, how do you decide on the topics you want to treat? And I want to say that before we even start today's class, that's exactly what I want to focus on. So how do you even find out? Okay, Dr. Moajon says Ontario, the weather is very nice. That's good. That's very, very good to know. And Calgary as well is represented Dr. Irene Owusu-Ajiman. Then we also have Dr. Joanna De Cruz. Dr. De Cruz is also joining us. Awesome doctors, So someone was asking me, Dr. Bruni, please, how do we know? How do we know? Dr. Hanif is joining us from Toronto. Beautiful, beautiful. So how do we know? How do we know? So today I just wanted to share, something quickly. So let me go to Google, just so that you can see what all the enabling objectives and everything is about. Okay, so let me go to Google. Okay, so if you see my screen, please, do you see my screen? Do you see my screen and can you hear me? Yeah. So if you go to Google and you want to find out about, the enabling objectives and everything, why is Dr. Bruni dealing with child abuse, for example, today? So I just go to MCCQ1 objectives. Okay, MCQ1 objectives. Now it will open quite a number of things for you, and it will bring you here to this page. Okay, MCQ1 objectives, and then you open that link. When you open it, scroll down and go to this point, the medical expert section. Okay, if you click on the medical expert section, you just scroll down, because the exam or the Medical Council of Canada is assessing you on so many roles: a doctor, as a medical expert, as a collaborator, as a communicator, and this comes on a lot in your NACOSKI, collaborator and communication, right, and health advocate, and then as a leader, as a professional, as a scholar. All right, now I clicked on the medical expert part. So under the medical expert, that is where you will see the objectives listed as A, B, C, D, E, F, G, H. It goes all the way to the last one. I think the last objective is about white blood cells abnormalities, and we've dealt with a topic on that where we dealt with HIV and the rest. Right now, so for example, for today, why did we choose this particular topic? Because it's under the objective violence and family. And when you open it, we have child abuse, then we have elderly abuse, and we have adult abuse. Now, there's a document which goes with this, which is about 441 pages. Okay, because every objective has its enabling objective, main objective, and then other things, and they really describe what goes into the child abuse and what they want you to know so far as that exam is concerned, right? And then we have shrunk everything down, and we have even categorized everything into systems, because you realize that, like under V, you have vaginal bleeding, which can fall under either obstetrics or gynecology. You have vaginal discharge, and then vulvar pruritus, right? You have violence and the family. You have visual disturbances. So under V alone, you have topics which are covering ophthalmology, gynecology, obstetrics. Vomiting and nausea can be under emergency medicine. It can be under gastroenterology. It can be under so many systems. So we have taken our time to break all these objectives down and rearrange them into ways that we can remember. So remember that in medical school, you say, okay, you're doing the cardiology class, or you're doing a nephrology class. So we've broken all these down. So if you want a copy, just send me a text message, okay? On WhatsApp, I prefer WhatsApp. If you send me a WhatsApp message, I'm sharing the phone number underneath the screen, +1 306 891 5649, +1 306 891 5649. So if you send me a WhatsApp message, I will share a PDF of like how we have grouped all these objectives into systems. So emergency medicine, cardiology, and all those things. And it makes your learning very, very easy. Okay, it makes your learning very, very easy. So yeah, we will jump into the class right away. Let me see. So I'm hoping you're all doing well, and today's class is going to be a fascinating class on child abuse. So I'm going to share my screen, and then we will all jump into the class. Okay, the reason is because tonight we have another class, I think on rheumatology, and then on Wednesday you have an exam, and then on Thursday you have a class. And this week we had, shared the link for the med drills, which is supposed to come on the 26th. But what we made a mistake. We realized that it coincides with the mock. So I'll be announcing a date for the med drills. We'll do it this week. Maybe Tuesday. I'm just thinking aloud. Maybe Tuesday. Okay, just so that we can go through it. But it also conflicts with those who are taking the NACOSCI class, and we have some people who are taking the NACOSCI class who are also in the Q1 class. So, but we'll see. We'll manage it and we'll see. We'll manage it and we'll see. Okay, so let me share my screen and then we start today's class. Let me see. Okay, so let me share my screen and then we'll start today's class. Okay, good. All right. So doctors, please, if you see my screen, let me know. If you see my screen on YouTube or Facebook, kindly let me know and then we'll get into it. So today's class is on approach to child abuse. Okay, very, very important objective, and you will get to appreciate why it is important. Like the reason why I love the Canadian exam is because it touches on so many things, including psychosocial things that at times we don't really pay attention to, when we are in the clinic and the rest, and especially depending on the jurisdiction in which you were trained, right? It depends on how it is presented. But in the Canadian context, you realize that there are some psychosocial things which you need to focus on, and the exam is not only about typical nephrology, cardiology, and all those things. There are some things which border on social things that we also need to know about. And so approach to child abuse is one of those very important topics. We have violence in the family, approach to elder abuse, approach to intimate partner violence. So if there are topics you need to review, make sure that while you're reviewing this particular class today, you're also going to review, all these things I just mentioned to you. Okay. All right. So doctors, we are about to roll. And if we are about to roll and you are with me, kindly let me know. Just text me that you are good to go, and then let's go. Okay. Think there's a portion of my thing which is frozen. So I want to make sure, please, do you see my screen? Can you hear me talk? If you can see me and can hear me talk, then let me know so that we can all get the ball rolling. I want to make sure that you can see me, you can hear me, and so you can get a ball rolling. Okay, good. So it looks like it's a yes for many people. Okay, good. So the rationale for this, and every objective you realize has a rationale, has a main objective, has enabling objectives. So the rationale for this is this: child abuse and trafficking are significant issues around the world that are often poorly recognized. You see the wording the medical council is using: poorly recognized. And timely awareness, evaluation, and reporting of suspected child abuse or trafficking is critical, allowing for early intervention to optimize outcomes for children and their families. All right, good. And then what are the causal conditions of child abuse? So the following are components of child abuse and human trafficking: physical abuse. And most of the time you realize that in a lot of our learning, we just focus on the physical abuse part. But the other things: sexual abuse, exploitation, that's a sex trafficking, emotional and mental abuse, child neglect, child marriage, forced exploitative labor, which is child or human trafficking, and then criminal activities like drug trade and theft, so far as these kids are concerned. All right. Now, what are the key objectives? Now, this is something you need to write down in your book. Please write it down. Send me a message on WhatsApp right now. Send me a message of the pages you are sharing. People do that, and Dr. Jagdeep and other people have done that. Dr. De Cruz has also done that in the past. Send me, a screenshot of the notes you are taking. I remember, yeah, other doctors have done that as well. Some CMGs, some IMGs have done that. So please just send me a screenshot. So the candidate should recognize the signs. So when you are learning this objective, you must recognize the signs, you must recognize the symptoms, and you must recognize the situations in which are potential for abuse. So in other words, you have to understand the risk factors associated with child abuse, right? So this is a key objective that you need to know: the signs, the symptoms, situations in which a potential for abuse exists. All right. Now, the enabling objectives are a lot, and that is what tells me that this is a very, very important topic. So, given a child with whom abuse or trafficking is suspected or disclosed, the candidate, that is you, taking a Q1 exam, will list and interpret critical clinical findings, including of possible abuse or trafficking, including suspicious injuries. So you must know, while you are learning this particular topic, which injuries can present and in which pattern will these injuries present. That will cause me as a doctor to think that this patient, is being abused. Okay, so suspicious injuries like fractures, like bruises, especially with consideration of the nature of the injury, the caregiver's explanation for the injury, and whether the explanation is consistent with the characteristics of the injury itself within the context of the child's developmental status. All right. Number two, suspicious circumstances. So not being registered with a school, being unsure of which country or city they are in, that is the child, right? Being orphaned or living apart from their family, giving a prepared story that is very similar to stories given by other children, and key manifestations like you have a child with sexually transmitted infections, a child who is pregnant, a child with developmental delay, a child with emotional and behavioral issues, a child who has failure to thrive. These are things that you want to pay attention to. And then you also want to pay attention to the family dynamics, right? Parental characteristics or a social situation that may be contributing factors. And these are things you need to really, really know offhand, right? And other potential signs like refusal by a parent or guardian to have the child interviewed alone, and potential mimics of child abuse. So that's another thing. You must know child abuse, but you must also know things which may mimic as child abuse. And one of the things is accidental injury. The child actually got injured accidentally, or a medical condition like osteogenesis imperfecta. Osteogenesis imperfecta. Because if you don't learn the mimics of child abuse, osteogenesis imperfecta, the child may present with multiple fractures, right? Because of the fact that they have issues with connective tissue development, especially bones, right? And in the child abuse class, you will also learn that, look, children who are abused may have injuries in various stages of healing. And so, for example, if you are not careful and you do like a bone scan in a child who has injuries, and you see that, you also have to think, okay, are there medical conditions which can present similarly? One of them can be osteogenesis imperfecta. All right. Now, list and interpret critical investigations, including radiologic studies directed at treating the current injury and investigating evidence of previous trauma, and other investigations as indicated, like coagulation studies, toxicology studies, psychological assessment, and then construct an effective initial management plan, including diligent documentation, because don't forget that child abuse can easily end up in the courts or can easily take on a legal issue. And so as a doctor, you must learn how to document properly, right? And outlining strategies for ensuring the child's safety, including specifically reporting to the appropriate child protection services, reporting to police services when appropriate, determining whether other children are at risk and should be examined, and admitting the child to the hospital until their safety can be definitely established. And number three, referring the patient for further evaluation and or treatment to like a pediatrician, a counselor, a social worker. So that's what I'm saying, that this particular objective is deep and is a lot. Now, there are some ways of reviewing child abuse for the MCQ1 exam. Like you can look at reviewing the child abuse concept from the diagnostic and evaluation management perspective. You can also look at reviewing child abuse from the medical child abuse perspective. You can look at it from the social and medical legal aspects, like what do you do if a child comes in to the ER and you suspect child abuse or there is obvious child abuse? How do you go around it? You can also look at it from differentials from a dermatologic perspective, right? Like skin manifestations of child abuse. You can also look at it from orthopedic aspects of child abuse, as well as evaluation and management of head injury in child abuse. That is something on its own, where the child will present with specific types of fractures on the skull, sometimes some subconjunctival hemorrhage and everything. As well, you can also look at child abuse from, the epidemiological point of view. So epidemiology, mechanisms, and types of abusive head trauma in infants and children. And you can also look at differentials of suspected child abuse. We've already talked about two of them. That is accidental injury and osteogenesis imperfecta. So what I'm just trying to say is child abuse is not just about, report to child protection services, like what people say in group studies, right? There's more to it. And especially now that the MCQ one is going as MCQs alone, you want to make sure that for every objective, you are acing it. And that is why I'm very, very happy about the way candidates are seeing a significant improvement in their mock exams, because someone starts with 150 over 230. By the third mock, they are scoring almost 200. And that is what makes me happy about the preparation people are putting in so far as the exam is concerned. So for today, we are going to focus on how to recognize physical child abuse for the MCQ1 exam, because this is very, very important. And how to recognize physical child abuse for the MCQ1 exam, it's a merge of, pediatrics and emergency medicine. And the reason why I'm talking about emergency medicine a lot in these days is because if you look at the MCC's table, emergency medicine covers 30 to 40% of the questions. So maybe let me stop sharing my screen and let's do this, because a lot of people don't know how questions are distributed on the MCQ1. Okay, so let me just share my screen and then you will see why I'm focusing so much on this particular thing. So if you go to Google, okay, and you just type MCCQ1, we'll come back to the lesson, but I just want you to see something. If you go to MCCQ1 and you go to MCQ1 part 1, okay, now this table is very, very important. This table I'm showing you is very, very important. Why am I focusing on child abuse and how to recognize physical child abuse in the emergency room? Because a lot of the cases of physical child abuse will present in the emergency room. Now, if you are learning for the QE1, okay, health promotion and illness prevention, it must cover about 15 to 25% of the things you are studying. In the exam, you're going to see about 15 to 25% of the questions. So out of every 100 questions, you may see 15 to 25 of them focusing on health promotion and illness prevention. So that's where, you talk about screening. That's where you talk about, all those interventions you put out on public health basis, right? That's what you talk about, public health. Now, acute, and this is where my emphasis is, you realize that it's going to cover about 30 to 40% because it's 35 plus or minus 5. So 30 to 40% of the questions will come from acute situations. So that's why your emergency medicine preparation must be top notch. And I'm going to look for this book because it's very, very important. And I'll show it to you. Good. I found it. This book, Centenary. Okay. This is the recognized textbook the Medical Council wants you to use. Maybe let me unshare my screen and so that you see it very well, because my image is very little. Okay, so Centenary. There are two forms. We have just the facts and then the deep book. But for the QE1, you can use just the facts. But you don't need to worry about it because we've done everything for you in the MedCognito program. I'm just trying to draw attention. This is the book that the Medical Council wants you to use to prepare for emergency medicine. This is the same book that if you get into family medicine in Canada and after a family medicine residency, you want to do a +1 in emergency medicine. This is the same book you'll be using. Those who do the 5-year emergency medicine program, they use a book we call Rosson's. Okay, don't worry about that, all those books, but I'm just letting you know why I'm focusing on recognizing physical abuse for the MCQ1 in the exam. So let me go back to what we were discussing. Okay, good. So you know, I was talking about the fact that 30 to 40% of the cases will cover acute medicine. Okay, and then 25 to 35% of the cases will also cover chronic conditions, and then psychosocial aspects will cover about 10 to 20% of the cases. So let's take a typical case about glucose abnormalities. There's a whole objective about that, where you talk about hypoglycemia, hyperglycemia, diabetic ketoacidosis, complications of diabetes. So if you're using diabetes alone, or even let's even take child abuse, which we are discussing today, you have to ask yourself, you know, 15 to 25% of the cases are going to cover what to do on a public health basis to prevent or to deal with child abuse. So where you realize that in the class today, we'll be talking about things like screening for child abuse. Then if you are dealing with child abuse alone, you realize that 30 to 40% of the cases you should deal with child abuse and as it presents in the emergency room. So if you see a child with subconjunctival hemorrhage, if you see a child with, say, frenulum tear, if you see a child with abuse like trauma to the ear, if you see a child who is not walking, you know, a 3-month-old baby who has a femoral fracture, it should ring a bell, right? And then the chronic issues can be, you know, a child who comes with a caregiver but does not want to stick with a caregiver, comes to the clinic, it should ring some alarm bells, as well as psychosocial aspects. That is, what are the social dynamics in the home that can be a risk factor for child abuse? Now, if you go to the right side, you realize that you're also going to be assessed on assessment, management, communication, and professional behaviors. Professional behaviors is what a lot of people talk about as ethics, right? So you must look at your exam preparation in this context. Every topic you pick, child abuse, health promotion and illness prevention, what is it about it? Acute presentations of child abuse, chronic presentations of child abuse, psychosocial aspects of child abuse. Then how do I assess a child who's been abused, right? How do I manage a child who's been abused? Who do I report to? Which specialist do I refer to? And then how do I communicate? Which other healthcare team members do I bring on board? And then professional behaviors, what are my ethical obligations so far as child abuse is concerned? Because today we are going to also learn in the class that, look, you have some ethical obligations so far as being a doctor is concerned. Doctors, please, did that make some sense? I want to know, did that make some sense? All that I just did it make some sense? Did it make some sense with all that, like using child abuse alone and going through that particular table? Did it make some sense? Okay, yeah. For those who are asking for the objectives book, just send me a message on 306-891-5649. After the class, I'll send you a copy right away. Okay, good. So now, doctors, let me share my screen and then we continue the class. I'm happy because I want to always make sure that I'm hitting on that particular table, because a lot of people don't pay attention to it. They just study and they study amiss, right? They study amiss. Okay, so let's start with the question. Doctors, I need 1 or 2 people to join me so you guys can also help read the questions, because the questions are a lot, right? So please, if someone can join me, I'll appreciate it. Dr. Sabine, usually I know that you like to join me, or any other doctor, just put on your camera, join me so that you can help me with reading the questions, and then we can go. Okay, so you have, and I'm going to share the link. So if you want to join me, I'm just sharing the link, okay, so that it can be a bit interactive. Yeah, if you want to join me, just click on the link, put on your camera, make sure your microphone is good, and then you can help read the questions for your friends on Facebook and on YouTube. Okay, I'm sharing the link so that you can use that to join me. I can take a maximum of I think 4 people or so. Okay, so let's go. So you have a 44-month-old infant who is brought to the emergency department with a history of persistent crying and decreased feeding. On physical exam, the child is irritable and has multiple ecchymosis on various or varying ages on the back and the thighs. The mother explains that the baby bruises easily. Okay. Okay, good. Oh, good, good, good. Okay, Dr. Riosoti, thank you very much for joining me. Okay, thank you. Okay, so the family recently moved and the mother is reportedly unemployed and caring for the 3 children alone. She has no documented psychiatric or substance use history. Which of the following statements best explains why the child's abuse may have gone unreported until now? Which of the following statements best explains why this child's abuse may have gone unreported until now? A, the child has a medical condition that explains the bruising. B, the frequency of visits to health services for routine checks is too high. C, abuse reporting is more likely when children live in 2-parent households. D, abuse is often unrecognized due to underreporting and lack of identification. And E, bruising in non-ambulatory infants is common and usually benign. So Dr. Risati, when after this, then you will read all the questions for us. Thank you very much for joining us. I really appreciate that. So doctors, what's the answer? Is it A? Is it B? Is it C? Is it D? Or is it E? Think so far only Dr. Ihioma Bright has answered D. Okay, the answers have started coming through. Good. Good. The answers have started coming through, and I think that is the correct answer. Abuse is often unrecognized and due to underreporting and lack of identification. So D is the correct answer. Only 5% of physical abuse cases are actually reported to child protection services. Okay, and abuse, especially in non-verbal or younger children like infants, may go unrecognized due to subtle signs or lack of suspicion by healthcare workers. Okay, so the correct answer is just D. So Dr. Rasoti, you take the next question for us. You can just read it aloud and then we will all jump. Thank you.
Yeah, thank you, Dr. Brody, for this privilege. The hospital administrator
Well, we can't hear you. Doc, we can't hear you.
I'm not muted.
Can you check your camera for me? Can you speak? And then I'll just try to hear. Okay, good, good.
Can you hear me?
Yeah, I can hear you now.
Okay, thank you, Dr. Brody. A hospital administrator is reviewing emergency department data to assess how the COVID-19 pandemic affected child maltreatment. Reports show a decrease in official child abuse cases during the early months of the pandemic. Which of the following best explains the observed decrease in reported child abuse cases? A, increased parental awareness due to public health education. B, actual decline in physical child abuse due to economic support. C, closure of schools and daycares limiting abuse identification. D, improved child protection agency infrastructure during the pandemic. And E, reduced number of children in at-risk households due to foster placement.
Okay. So doctors, please, can you please give us your answers? Is it A? Is it B? Is it C? Is it D? Or is it E? For this second question. Okay, so the hospital administrator who is reviewing the emergency department stuff, which Dr. Riasoti just read, is it A? Is it B? Is it C? Is it D? Is it E? It looks like a lot of people are going for C. C, closure of schools and daycares, limiting abuse identification. Did anyone go for any different answer? I think someone went for B, but the correct answer is C. Because during the COVID pandemic, schools were closed down, So it's limited abuse identification. And most of the time, you'll also realize in your learning that abuse is also identified mostly by teachers as well. When the child comes to school with, the way the child is presenting, right? So during the pandemic, children were sequestered away from schools and daycare centers, which are major sources of abuse detection, as I said, right? And this contributed to lower reporting, not necessarily lower incidents. In fact, it is likely that during the course of the pandemic, abuse cases went up. But because the children were sequestered at home, the identification of those abuse cases was very low. And because of that, we had less reporting. Good. Dr. Riasoti, next one, please.
Thank you. A 7-month-old boy is brought to the clinic for irritability and poor feeding. The mother reports multiple falls from the couch in recent weeks. On examination, the infant has bruises on his chest and upper arm. He was born following an unplanned pregnancy to a 17-year-old single mother who is unemployed and lives with her parents. The family has moved twice in the last 6 months. There's no prior child protection service involvement. Which of the following is the most significant clinical red flag for physical child abuse in this case? A, child's irritability and feeding issues. B, young maternal age and unemployment. C, frequent bruises with inconsistent explanation. C, please take that
Okay, good.
answer
So,
of Teva Ahmad down. Take the Teva Ahmad's answer down.
okay, good.
The answer is blocking my view.
Okay. So,
Dr. Bode.
so class, is it
Okay,
A?
history
Is
of
it B?
history of
Is it
multiple
C?
household
Or is it
relocation,
D?
the parents living in the home.
Hmm. So I see some are going for young maternal age and unemployment. Others are also going for frequent bruises with inconsistent explanation. Which of the following is the most significant red flag for physical child abuse? And the correct answer is C. The red flag. The, the correct answer is C, right? Frequent bruises with inconsistent explanation. So C is correct, right? Bruises in a non-ambulatory child. So let's look at this. 7-month-old boy. A 7-month-old boy, most of the time by 7 months, they are not walking, right? So bruises in a non-ambulatory child, and that is the trick there. So it's not just about the answers down there, but then what is it that screams out? I know that if a child is irritable and has feeding issues, it's a risk factor for abuse. Young maternal age and unemployment is a risk factor for abuse, but something else is in the question which throws more light on it, right? This is a 7-month-old baby. This is a 7-month-old baby who is probably not walking, but has all these bruises. So that is where the problem is. So frequent bruises with inconsistent explanation will be the right answer, right? So bruises in a non-ambulatory child, especially with explanations that do not match developmental ability, are a strong indicator for physical abuse. So again, I'll say it again. A child being irritable, having issues may predispose. A maternal age, which is very young, a family which is struggling financially from unemployment, you know, can be a risk factor. However, in this particular case, what stands out most is the fact that this child is 7 months old and has multiple bruises. So that is why the answer is C. Okay, Doc, next question, please.
Yeah. A 3-year-old boy is brought to the emergency department by his mother, who reports that he fell downstairs. On examination, you notice patterned bruises on his upper arms and buttocks. The child is quiet, avoids eye contact, and has notable language delays. His past medical history includes failure to drive and severe missed well child visits. Which of the following child characteristics most strongly increases this child's risk for physical abuse? A. Missed well visits. B. Male sex. C. Language delay and failure to thrive. D. Quiet temperament. And E. Young age.
Good. So, doctors, please, what's your correct answer? Today's questions are a bit tough, right? They are a bit tough, like the way the questions are put. Is it A? Is it B? Is it C? Is it D? Or is it E? Most strongly increases the child's risk for physical abuse. So I see a lot of C's, but I also see crack MCCQE states A. Right? Okay. And what's the correct answer? The correct answer is C. So please check it well. The correct answer is C. C is correct. Speech and language delays and failure to thrive are known child-related risk factors for physical abuse. And children who cannot effectively communicate are more vulnerable and less likely to report abuse, because if the child cannot communicate, they cannot even tell you that, look, this is what my parents are doing to me. All right? Good. Doc, please, let's go with this next question.
Yeah, beautiful. An 8-year-old boy presents with facial bruises that his caregiver says were from a bicycle fall. On further inquiry, you learn that the child has attention deficit hyperactive disorder, lives in a low-income household, and is being raised by a single father who with poorly controlled bipolar disorder and a history of alcohol misuse. The father had been physically abused as a child. Which of the following best describes the reason this child is at especially high risk of physical abuse? A, the presence of a mental illness in the father. B, cumulative risk from child, caregiver, and environmental factors. C, single parenting in a low-income home. D, a childhood diagnosis of ADHD. And E, history of parental alcohol misuse.
Good. Good. So, which of the following best describes the reason this child especially, there are so many risk factors in there, but which of the following best describes the reason this child especially is at high risk of physical abuse? Is it A, the presence of mental illness in the father? B, cumulative risk from child, caregiver, and environmental factors? C, single parenting? D, childhood diagnosis of ADHD? Or E, history of parental alcohol misuse? And doctors, look at the question very well. This child is especially at high risk of physical abuse. Why? The correct answer is B, because there's a cumulative risk from the child. Look at the risk. The child has ADHD, so that is a child with a difficult temperament. B, the child has poorly controlled psychiatric illness, that is the bipolar. The parent also has substance abuse. The parent also has a past history of abuse, and it looks like the home environment itself is stressful. So when all these things come together, they become a cumulative risk, which dramatically increases the child's risk of abuse. That is it, right? Doc, we good? I think that is fine. Okay, good.
Yes.
So let's do a deep dive to the introduction of child abuse, and then so this was just introduction, so that we're going to do a deep dive into it. So what is physical child abuse? As I said, today we are just looking at identification of yeah. What's the definition? So physical child abuse is injury which is caused intentionally by a parent or a caregiver. So now the whole thing is that for every 100 abuse injury, only 5 may be identified by the system. And that is why the Medical Council wants us to really, really learn this particular topic very well. For every 100 abused children, only 5 of them may be identified by the healthcare system. Okay. Now, what are the risk factors for abuse? When you're dealing with risk factors for child abuse, you have to look at child characteristics, you have to look at the environmental characteristics, and you have to look at the caregiver characteristics as well. So 3 areas. You want to look at the child, the environment in which the child is growing, and the caregiver. Okay. Now, what are the child characteristics? You want to look for a child. We are looking at risk factors for child abuse. You want to look for a child who has speech and language disorders. That's number one. Number two, a child who also has learning disabilities, because then the parents easily become, or the caregivers easily become infuriated, right? A child with conduct disorders, as well as non-conduct psychiatry disease, and a child with failure to thrive. So doctors, please write these down. A child with failure to thrive, a child with congenital anomalies. Why? Because it makes, the life of the parents a bit tough, right? A child with intellectual disability or other disabilities, as well as a child with chronic illness. Sorry, I should have put illness there. Chronic illnesses, and a child who also has recurrent illnesses, and a child with attention deficit disorder with hyperactivity, as well as prematurity and low birth weight. Even though the data is conflicting there, we also have children who were born out of an unplanned pregnancy, leading to children who were not wanted in the first place. So these are the child characteristics that we need to know. So in the MCQs, we must be able to identify child characteristics that predispose them to abuse. Child characteristics that predispose them to abuse. Now let's look at the environmental characteristics. An unrelated adolescent or male adult caregiver in the household. So for example, a nanny who is not related to the child in any way. Number two, an unrelated adult male. So maybe this is a child of a particular woman, and there's a breakup between the woman and the child's father, and the mother of the mother of the baby has gone in for a new male partner, right? That partner can then go on to abuse that child. Okay, so someone says, what's the basic reason for a child abuse being unreported? Number one, assuming it's the parent who is causing the abuse, the parent may not take the child to the hospital unless the injury from the abuse is so severe. Number one. Number two, it could also be cultural issues. So if you read some literature very well, while I was combing through some of the literature, it was saying that some things which are considered as abuse here in Canada, some cultures don't see it as abuse. So if you have somebody who is coming from a culture which does not see whatever, maybe spanking or something, as abuse, and they come into Canada and that is what is going on, and there's even another adult in the home who needs to report it because they think that it is normal, it's not going to be reported, right? And then some also think that, look, if I report it, they are going to take the child away from me, that kind of thing. So that's also something. And then other environmental risk factors for child abuse can be animal cruelty. So in an environment where people are cruel to animals, they can also be cruel to children. And acute or chronic family stresses. So if there's something like divorce, interpersonal conflict, illness, or a job loss, that is a risk factor for child abuse. And another risk factor is children who come from households where there is poverty, as well as social isolation, like distant or absent extended family. Reason is because, if you have a child in a particular environment, they are sequestered, nobody comes there. The caregivers can do anything to that child, knowing very well that no other adults from the extended family may come to see the situation and report it. So that's also a reason why these things happen. And then caregiver features of child abuse. If you have very young parents, or you have single parents, so at times they may be abusing the child all the time and blaming the child that, look, it is because I got in with that father of yours, that is why you were born. And so they put all their anger on that particular child. Okay. And then parents with lower levels of education and unrealistic expectations from the child, or poor knowledge of child development. Okay. And then negative perception of normal child behaviors can also predispose caregivers to abuse the children. And a caregiver who was abused or neglected as a child, so they grow up thinking that that is normal. Okay. and that leads to abuse or neglect of their own children, as because it's a learned behavior. That is how that caregiver was groomed when he was young, and that is the same thing he's going to do to his children. And substance or alcohol use disorder, as well as poorly controlled psychiatric illnesses like psychosis, depression, impulse disorder. So these are the caregiver features. So you have to learn the caregiver features. You've got to learn the child features. You've got to learn the environmental features which predispose children to abuse. Okay, now how to remember the risk factors for child abuse. This one I need you to write it, so I'm going to take my time and go through it one by one. Okay, so all the risk factors I put there, if you remember this acronym, child hurts, child hurts, the child hurts, child abuse, child hurts. This is very, very important. So C is caregiver stress. So caregiver stress, like financial issues, mental health issues. Okay, please write this down. H is history of abuse in the caregiver as a child. So we've gone through all these factors, but I just put it child hurts, so you'll be able to remember it for your MCQ1 exam. Okay, and then isolation, where there's limited social support. Okay, and then L stands for low socioeconomic status in the adults in the home, and then these developmental or physical disability in the child, and H is household instability, where there's frequent moves, divorce in the household, and U is unwanted pregnancy or an unwanted child, and R is recurrent injuries or recurrent ER visits, and T stands for teenage parenthood, and S stands for substance abuse in the caregiver. So please, doctors, if you can write this down, we have so many acronyms for depression, acronyms for panic attack, acronyms for what to do to an emergency medicine patient who comes through the door. So I'm just giving you this acronym: child hurts, CHILDHURTS. If you remember this, it gives you a framework to remember all the risk factors for child abuse. Now, what are the consequences of missed child abuse? Consequences. Dr. Riasuti, please take it for us.
Yeah, thank you. A 14-year-old girl is brought to the emergency department with seizures and is diagnosed with subdural hematomas consistent with abusive head trauma. Review of past visits reveal she's been seen twice in the previous 2 months for accidental falls in quote, where she had facial bruising and a torn frenulum. No child protection reports were filed. Which of the following best explains the missed opportunity for earlier intervention? A. Facial injuries in toddlers are common and do not require documentation. B. The injuries were not severe enough to warrant suspicion. C. Prior visits represent sentinel events often missed by clinicians. D. Child abuse cannot be reported without eyewitness confirmation. E. Repeat visits are only concerning if the caregiver story changes.
Good. Good. So facial injuries. So which of the following best explains the missed opportunity for earlier intervention? So I can see a lot of C's, a lot of C's, a lot of C's. And the correct answer is C. So prior visits represent sentinel events which are missed by clinicians. So what are sentinel events? Sentinel injuries. What are they? Sentinel, when we talk about sentinel, it's like a warning shot. Boom, right? So sentinel injuries are minor but concerning signs of abuse. So like bruising in the non-ambulatory children, torn frenulum. And when these cases were being brought to the emergency room over and over again, the doctor didn't really think, could it be that this child was being abused, right? And all those things were there till the cases started escalating. And they are often missed at earlier encounters. And in the cited study, 1 in 4 children with abusive head trauma had prior opportunities for being recognized, but the doctors couldn't recognize it. That is why the medical council has noted that child abuse is often recognized by doctors, and so we are going to be quizzed on it in our main exam, right? So sentinel injuries, these are injuries, man, today the child has come with a laceration here, the next day the child has come with this, and the doctor is not able to pick it up. That is where the issue is. Okay. Sir, please take the next one for us, please.
Yeah, thank you. A 10-month-old infant presents to the emergency department with a femur fracture. The caregiver states the child rolled off the couch. On reviewing records, you find that the child was seen 6 weeks ago for a rib fracture attributed to rough handling by a toddler sibling. No CPS report was filed. The infant is discharged again without follow-up. Which of the following is the most critical consequence of failing to intervene in such cases? A. Delayed physical development due to fracture pain. B. Parental fear of seeking future medical care. C. Continued abuse with increased risk of fatality. D. Higher hospitalization costs for repeat visits. And E. Increased risk of litigation against the provider.
Thank you. Thank you. So what's the correct answer, doctors? Okay, Dr. Rossetti, you're sending me the answers privately. Thank you very much. That's good. I've seen the answers. So what's the correct answer here? The correct answer is C, right? Children returned to abusive environments without intervention have a 33% chance of repeated maltreatment and increased risk of death. Why? Because now even those people who are abusing the child become emboldened, right? They get to know that, oh, when we took the child to the hospital, the doctors couldn't even pick that something was wrong. And so they will continue doing that. And there's a 33% chance of repeat abuse, repeat maltreatment, and increased risk of death in that particular child. Dr. Rasuti, next one.
Okay, thank you. During grand rounds, it represents a case of a toddler with multiple emergency room visits for minor trauma over 6 months. No interventions were made, and the child is now hospitalized for abusive head trauma. A faculty member emphasizes the need for better recognition of abuse. Which of the following strategies is more supported by current evidence to address this issue? A. Wait for visible injury to worsen before suspecting abuse. B. Implement universal screening protocols in children. C. Increase training for law enforcement officers. D. Restrict social work involvement to inpatient cases only. And E. Require child witness to confirm abuse before reporting.
Good. Thank you. So which of the following strategies is most supported by current evidence to address the issue of recognizing abuse? So this is where something like, pediatrics meets emergency medicine and public health, right? So remember that in Canada, we want to mix things up a little bit. And this is the correct answer. The correct answer is B, implementing universal screening protocols in young children. Okay, so universal screening in infants and young children is a proposed strategy to improve early detection and reduce clinical bias, especially since early signs may be subtle. So what's happening is that there's a push to start screening all children who come to the emergency room for abuse, no matter the presentation they come with. Okay. So the consequence cycle, I call this the consequence cycle. We have 3 D's of abuse. Okay. Number 1, the first D is most of the time abuse is detected too late. The next D is, most of the time they are dumped back into danger, where like they are dumped back into that particular environment where the abuse was happening. And the third D is, if care is not taken, then there can be death or further damage to the child. This is the consequence of abuse and missed abuse cases in the emergency room. This is the vicious loop. they get detected late. Because of that, the doctor does not do anything about it. The patient goes back to that environment where they were being abused. And then last but not the least, if care is not taken, there can be further damage to the child or there can be death. Right? Now, what we have to understand is that 10% of abused children had already visited the hospital before the abuse was finally recognized. The second thing, and that's why I put the cycling thing there, 33% or 1 in 3 of children will be abused again if they are sent back to the same environment without intervention. Next point is that the risk of death rises when early signs are missed. And those early signs can be bruises, fractures, odd explanations from the caregiver. Next one in 4 kids with abusive head trauma had earlier visits with missed signs, what we call sentinel injuries. Okay, now, next point is that clinician bias plays a role. Ethnicity or socioeconomic status can unconsciously affect whether a doctor suspects abuse, and that's what I was talking about. And then without a clear red flag, many clinicians stay in a state of neutral awareness and they don't escalate to action. Oh, if I talk about this, the parents may be in trouble, that kind of thing. And because of that, the children are put back in the same environment and then the abuse worsens. So please, as we are learning this, eventually all of us are going to get into practice. Let's put child abuse, on top of our minds whenever children present to the ER, so that we can be able to pick up some of these things easily. Okay, so what is the remedy for missed abuse? How do we deal with it, especially since the medical council talked about the fact that abuse is usually missed a lot? Number one, recognize subtle injuries or repeated concerning visits. You have to recognize it. Number two, evaluate thoroughly even if explanations seem plausible. Number three, monitor risk of repeat maltreatment. Because don't forget that if a child presents the sentinel sign and we don't deal with it, usually there's a 1 in 3% chance that that child will be abused again. And E is escalate if you have red flags present. Don't do wait and see. And D is don't be biased by race or social class. Oh, they look well put together as a family, so they can't do any bad thing to the child. No. And then Y means yes. If you are in doubt, report. Look, if you are that the whole thing in Canada is that as a doctor, if you doubt that is this child safe or not, look, doctors, report. If the child protection services look into it and they don't find anything worrying, that is fine. Okay, so first you suspect something, report it. So why do we have to screen for child abuse? It levels the playing field and it reduces bias. Because as I said, if you're not careful, you say that, oh, this family, they look like they don't have money, so I'm going to look deep. Oh, this family, they look like they are good, they are well put together. Oh, the mother is a doctor, she's a colleague, the father is a lawyer, and therefore I'm not going to do anything about it. No. So if we are planning on screening for child abuse, it will level the playing ground. Whether you are a child of, whoever, or you are a child of someone who does not have money, it's a level playing ground. Okay. And it's especially crucial in infants and toddlers who can't speak for themselves, like people who are non-verbal. And it also helps catch sentinel injuries before they escalate. So now let's talk about early recognition and safe intervention to protect the child. Dr. Yasuti.
Yeah, a 9-month-old infant is brought to the emergency department for increased responsiveness and vomiting. The caregiver reports that the child fell off the couch yesterday, but this did not bring her immediately because she seemed fine until this morning. Physical examination revealed lethargy, a bulging frontal nerve, and bilateral retinal hemorrhages. A CT scan reveals a subdural hematoma, which is the most concerning red flag in this case that supports a diagnosis of physical abuse. 9-month-old infant. So vomiting in an infant. B, bilateral retinal hemorrhages. C, delay in seeking medical attention. D, history of fall from couch. And E, bulging fontanelle.
Good. Thank you. So, which of the following is the most concerning red flag in this case that supports the diagnosis of physical abuse? Most concerning: vomiting, bilateral retinal hemorrhages, delay in seeking medical attention, history of fall from the couch, and bulging fontanelle. What's the most concerning? I can see a battle between B and C. And what's the correct answer there? The correct answer is C. Now, a significant delay in seeking care after severe head injury is a classic red flag. I'll say it again, classic red flag for abuse, especially in the context of neurologic symptoms like altered mental status. Why didn't the parents bring a child who had altered mental status to the ER? Now, I know that people were talking about B, retinal hemorrhages. Retinal hemorrhages are also strongly associated with abuse, but are findings not red flags in the history. So, retinal hemorrhages are things you will see on examination. That is not something the parent will tell you, right? Now, let me go back to the question. It says, what is the most concerning red flag in this case that supports a diagnosis of physical abuse, right? So, retinal hemorrhages, yes, you'll pick it up when you do your own fundoscopy and ophthalmoscopy. However, the most significant thing is that there's a child who lost consciousness or, had altered mental status, but the parents did not even think about bringing the child to the emergency room. Okay. Now, falls from couches are inadequate to explain severe injuries like subdural hematoma, but delay is a clear red flag. And especially this child is also a 9-month old. So 9 months old, at least they are moving a little bit. Maybe the parents put the child in the couch and they left and they forgot. And that happened. And remember that bulging fontanelle can happen in other medical conditions like even meningitis, right? So that is not the most significant red flag here. The most significant red flag is a child who had altered mental status for whatever reason, and the parents refused to bring the child to the hospital. Dr. Riosuti, next one.
Thank you. A 7-month-old non-ambulatory infant is
Next
brought
question.
with a spiral fracture. The caregiver states that the injury occurred when the infant fell down the stairs in a walker. On further questioning, the caregiver becomes evasive and their account changes slightly with each retelling. There is no delay in seeking care. Which historical feature most strongly supports a diagnosis of physical abuse? A. Spiral fracture. B. Lack of bruising. C. Walker use. D. Changing history. E. Caregivers' evasive behavior.
Good. Look at the question very well. Which historical feature most strongly supports? So, spiral fracture, is it a historical feature? Lack of bruising, is it a historical feature? Walker use, is it a historical feature? Changing history, is it a historical feature? And then caregivers' evasive behavior, is it a historical feature? So, which historical feature most strongly supports a diagnosis of physical abuse? And the correct answer is D, the changing history. Now, changing trauma history, especially for significant injury, is a classic red flag. Now, even though spiral fracture can be suspicious, it must be evaluated in the context of history and developmental age. And remember that spiral fracture is not something you pick up from history. You pick up from exam and further imaging. So that makes it wrong. Even though spiral fracture indicates that there could be abuse, okay? And then absence of bruising does not rule out abuse because they can have abuse and it may not be physical. And walker injuries can occur, but this alone is not diagnostic. And evasiveness raises concern, but is less specific. But if you're looking at one of the topmost things, which is a red flag that this is a case of abuse. Oh, the child was jumping over the gutter and it happened. The next one, the same parent will say, oh, the child was on a trampoline. Changing history is one of those things that you want to watch out for. Dr. Real City, next one.
Yeah. An 18-month-old child presents with a femur fracture. The caregiver attributes the injury to the child's 2-year-old sibling jumping on him. The physical exams reveal multiple bruises in various stages of healing. Which element of this history is most concerning for abuse? A. Bruises at different stages. B. Attribution of injury to a younger sibling. C. Femur fracture. D. Male gender of the sibling. E. Parental presence during the injury.
Thank you. Thank you. And I see here some are going for A, some are going for B. So I see A and B. So, doctors, you see how deep this whole child abuse thing is. As I said, child abuse is not just about, oh, you see a case of child abuse, report to Child Protection Services. There's more to it, right? There's more to it. So what's the correct answer here? The correct answer is B, attributing the injury to a younger sibling. This is a patient who has had femur fracture, and if you've seen a femur fracture before, it's very critical, right? Serious injury, that is like a femur fracture, being blamed on another child, is a classic red flag. Okay, now bruising supports abuse, but the red flag in the history is the blame. And femur fracture is suspicious, but again, we focus here on the history. Okay, and gender is irrelevant, and supervision doesn't justify a serious injury from a toddler. So here the answer will be B. Next question, Dr. Resoti.
Beautiful. A 10-month-old infant presents with vomiting and lethargy. The caregiver reports the infant fell off the bed last night and only brought them in because they seemed more sleepy this morning. A CT shows a subdural hematoma and cerebral edema. The child has no external bruising. Which finding in the case best meets the criteria for a red flag history? A. No bruising. B. Fall from bed. C. Cerebral edema. D. Delay in seeking care. E. Absence of retinal hemorrhage.
Good. Which finding in the case best meets the criteria for red flag history? Red flag history. Oh, someone wants me to go back to the previous case. This one, Dr. Yvette, she said somewhere here. Sorry, I'm just trying to go back. She said the question was about physical exam. No, Dr. Yvette, the question was about history. Which element of this history, please? All right. Have you seen it? Okay. So now let's go back to this current question. Which finding in this case best meets the criteria for red flag history? And the correct answer is delay in seeking care. That is D, right? Delay in seeking care. I don't think this one anyone has any issues with it. That's the correct answer. Okay. Dr. Wilsity. Okay, so what to do in the ER? If you imagine a child presenting to the emergency room and the symptoms don't fit the usual medical explanations, behind the scene may be something more serious like abuse. So a child comes to the emergency room, the symptoms they are presenting don't fit the usual medical presentation. Doctors, please think about, think about abuse as one of the issues. So your job is like that of a detective, okay? You must look past the symptoms to ask, examine, assess, and act. So that's what you have to do. Okay, so I have this acronym as well, which we use, which stands for START aid. What do I mean by that? So if you have a child who comes to the emergency room with abuse, suspected abuse, first you want to stabilize the child. That's your duty in the emergency room. You want to stabilize the child. First, manage the life-threatening conditions and prioritize ABCs of the child. That's the first thing. Number two, think about trauma. So if symptoms like vomiting or altered consciousness lack a clear explanation, there's no fever, there's no complaints of abdominal pain or anything, think about trauma. A, ask about trauma. So you think about it and you ask about it. So get a detailed history that covers the full symptom timeline. And the best thing is that separate the caregivers and ask the questions separately. Because if they are together, then they'll corroborate each other's story. But if they are separate, they don't know what the other person said in the other room. Okay. Now, R is review the body. Do a full body exam, especially the mouth, the scalp, the ears, the genitals of the baby or the child, the buttocks, the body folds like the armpits, the groin, and look for bruises or patterns. And then tease 3 key questions for each injury. And I'm going to put the 3 key questions on the next slide. For each injury, ask about, does the shape or the pattern suggest abuse? Okay. Look for loop marks, immersion injuries. Number 2, the next question you want to ask is the injury statistically linked with abuse? For example, if you see injuries like rib fracture in a child, subdural hematoma in a child, think about abuse. Next one, does the story match the injury? Does the timeline match the injury? And does the child's abilities match the injury? That's something you also want to pay attention to. Okay. So the A stands for assess the social history. Look for the stresses. We've already looked at that. Maybe a parent who is very young. Is there any stress in the home? Is there any divorce? Is there any, what is the social circumstance of the child? Is there any drug use in the house? Is there any history of violence? Is there a history of prior child protective involvement? If there is social work available, fall on social work. Okay. Now, initiate full evaluation. If you suspect it, begin a full child abuse workup. So far as you suspect child abuse, deal with it. Okay. And then document and report. Document clearly, report if any concerns remain. In most countries, there's a legal obligation. And don't be fooled by a normal story. The history might sound plausible at first glance, but check whether it aligns with the type of injury, the child's age and the child's abilities, and the timing and the progression of the symptoms of the child. Okay? Yeah. And then look for developmental mismatch. For example, if you are told that a 6-month-old fell off a bunk bed, how did this happen? A 6-month-old baby. Or you have a child who is non-ambulatory, a 3-month-old baby who has a femur fracture. Why? That means that something is going on. Okay. And when you see some injuries in your MCQE1 board exam, it should scream to you that this is non-accidental. This is abuse. For example, a child with rib fractures. Because don't forget that the bones of these children are very, they are very, I don't know how to, compliant. And it takes a lot for a child's rib to fracture. Subdural hematoma should tell you, bing, 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 bing. This is non-accidental. Immersion burns, like you see a clear line on the buttocks or the limbs, should tell you something, right? Patterned bruises. If there's a pattern to the bruise, like, you see an adult palm, or, you see cords, or you see a bite, that should tell you that no, there's something going on here. And then always ask them separately. Separate the caregivers and, look for inconsistencies in their stories and document very well. Now, this is also very important, and I need you to take either a screenshot or, to take a note or something. Bruises or injuries that are highly associated with physical child abuse in children less than 4 years. Bruises or injuries which are highly associated with physical child abuse in children less than 4 years. So we call it 10 for faces P. 10 for faces P. So the 10 is injuries on the torso. That should tell you that maybe there's some form of abuse going on. Injuries on the ear. Injuries on the neck. Injuries on the frenulum. An injury on the angle of the jaw or any bruise in an infant who is less than 6 months should tell you maybe there's abuse going on. Injuries on the cheek, especially the fleshy portion of a child, should tell you that maybe there's abuse going on. Injuries on the eyelid. So doctors, because the exam is going to be MCQs, that is why I'm taking my time to take these one by one, right? Injuries, which I say is subconjunctival hemorrhage. So why does this child have subconjunctival hemorrhage? Patterned bruises, like a loop, like a belt pattern, like a handprint, or recognizable striking objects. This should tell you that no, there's some form of abuse going on here. Doctors, please, are we all on the same page? This one, I need you to write them down. So if you see an injury in a child in any of these areas, it should point you, maybe, just maybe, there's abuse going on. The torso, the ear, the neck, frenulum, angle of the jaw, or any bruise in an infant, on the cheek, the eyelid, subconjunctival hemorrhage, pattern bruises. Okay, so I got this patterns, right? And I got it from Up to Date. Okay, so belt buckle. If you see this pattern, should tell you something. If you see the pattern of a belt itself, if you see a looped cord, so maybe the parent put some loop together and used it to strike. If you see the pattern of a whip, a fly swatter, you know, that thing we used to kill the flies in the house, and then maybe the mother just picked it up. You know, if you see the pattern of a coat hanger, you know, the pattern of a board or a spatula, the pattern of a hand or the knuckles, right, on the head, the pattern of a bite mark on the child, saucepan pattern, as well as paddles and hairbrush and spoon, because these are things which can easily be available to the parents, and then they can just pick it up and use it on the child. So if you see any of these, I saw this from Up to Date. It should tell you that no, there's a problem. Okay. And then what are the red flags of child abuse? We've talked about it a lot. Now I'm just coming to it. So if the caregiver offers no history or specifically denies history of trauma despite you seeing severe injury, boom, red flag. Number two, if there's implausible history or for the degree or the type of injury, for example, a child who cannot walk, who has developed a femur fracture, what happened? If there's unexplained or excessive delay in seeking care, so you look at the pattern of the injury, it looks like this happened 3 days ago, the mother is nonchalant about it, you know, that kind of thing. An injury attributed to in-home resuscitation efforts, where the mother, oh, and this happened, and we did CPR, and like all sorts of things, no. And if there's caregiver histories that change with retelling or conflict with versions from other observers. So grandmother who is telling the truth is telling a different story, and the mother who probably abused the child is also telling a different story. If there's a clash, it should be a red flag. And if there's severe injury explained as self-inflicted or blamed on other young children or pets, that is also a big red flag. So doctors, these are the red flags that I want you to pay attention to. These are the red flags of child abuse that I need you to pay attention to. Now, when we also go to physical exam, red flag exams, which should point you to maybe possible child abuse. If there is injuries to the scalp and the fontanelles, like this child does not have any fever, no signs of meningitis, but the fontanelles are bulging and the child looks semi-conscious or even unconscious. No, it should tell you maybe there is some head injury. Injuries to the ears, injuries to the mouth, the oral cavity, including the buccal mucosa, the labia, lingula, and frenula. Injuries to the teeth and posterior-pharyngeal wall. Injuries to the folds of the neck. Doctors, please note these down. It's an MCQ exam we are going for, right? Injuries to the buttocks, injuries to the genital area, injuries to the palms and the soles of the feet. These are red flag physical exam findings for child abuse. And what are some of the injury patterns that are suggestive of abuse? What we are doing now is deep stuff. So please, just know them very well. Any bruising in infants younger than 6 months of age, think about child abuse. If the child, so far as the child is less than 6 months, and there is any bruising in that infant, think about child abuse. Think about it. I'm not saying it says definitely child abuse, but let child abuse be on your radar. More than one bruise in a pre-mobile infant and more than 2 bruises in a crawling child. This is also another one, doctors. Next one, bruises located on the torso, the buttocks, the ear, the neck, the angle of the jaw, the fleshy part of the cheek or the eyelid. We've already talked about this, but I'm highlighting on it. Subconjunctival hemorrhages, as well as bruises with a pattern of a striking object like a slap, a belt, loop marks, spoons, spatulas, or other objects, and bruises with other previously reported abuse-associated patterns, as well as human bite marks. Doctors, these are the patterns that you need to be able to pick up in your QE1 exam. What about, let's go into the mouth itself. Mouth. If there's lip laceration or lip bruising, especially in non-ambulatory children. If there's a lingual or labial frenulum tear, especially in non-ambulatory infants. If there's a tongue laceration, especially in non-ambulatory infants. If there is bruising or wounds of the buccal mucosa, the gum, the palate, especially in non-ambulatory infants. If there is missing or fractured teeth with an absent or implausible history, that should also raise a red flag. If there's maxillary or mandibular fractures with an absent or implausible history, the mandible is broken. Why? If there's bruising or lichenification or scarring at the corners of the mouth from being gagged, that should also raise a red flag. And especially epistaxis. Even though epistaxis is common in older ages, epistaxis is rare in children. If you see a child who is less than 2 years with epistaxis, one of the things which should also go through your mind is abuse. Doctors, please, are we all tracking together? Dr. Rasoti, are we good?
Yeah.
Good. Beautiful. I'm just hitting on these. Bam, 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 bam. Doctors, please, in the comment section, let me know. Are we tracking together? So you realize that, as I said, abuse in children is not just, report to child protection services. At times you go for group studies and people are talking about abuse, child protection services. I'm like, yes, that is good, but there's more to it, right? Okay, good. So just want to let you know that on Wednesday, coming Wednesday, what's today's date? Today is 23rd. So 24th, 25th, 26th. On the 26th, we have a mock exam. That was the day we had also scheduled our med drill for emergency medicine, but because of this conflict, I'll need to decide on when we're going to have that particular med drill. But remember, on Wednesday, you have a mock exam. Doctors, you have a mock exam. And what I want you to just think about is, imagine walking into the MCQ1 with zero fear. That's what real exam simulation does for you. And the doctors who are taking the mock exams are seeing significant improvements in their performance, and that's how we do it at MedCognito. Okay, good. So Dr. Yasuti, please take this question for us.
A 2-year-old boy is brought to the emergency department for evaluation of burns on both feet and buttocks. The caregiver reports that the child accidentally stepped into hot bath water. On examination, you note bilateral symmetric second-degree burns with a clear line of demarcation just below the knee and around the buttocks, sparing the soles. No splash marks are seen. The child also has severe healing bruises on the upper arms. What is the most likely explanation for the findings? A. Accidental immersion during unsupervised play. B. Accidental scalding from a speed hot drink. C. Intentional immersion in hot water. D. Contact burn from a space heater. And E. Sunburn from prolonged sun exposure.
Okay, doctors. So is it A, B, C, D, or E? This is straightforward, and the correct answer is C. This is intentional immersion in hot water, right? Especially bilateral symmetric burns with a sharp line of demarcation. We call it the high tide mark. The high tide mark. Okay, especially because, look, if it is hot water, the person steps into the hot water with one leg, he will not put the other leg in it. It is when an adult is abusing that child that the adult will put both legs in the water, and that strongly suggests immersion injury in hot water, and it's a hallmark of intentional burns. Okay, and also the fact that there's lack of splash marks, because usually if you step in hot water it will splash on other parts, right? But then with the adults keeping the patient's foot in there, boom, that is very, very dangerous. And additional injuries, healing bruises support abuse. Okay, next one, Dr. Rasoti, please.
Thank you. A 4-year-old girl presents with multiple circular third-degree burns over her arms and legs, each measuring approximately 8 to 12 millimeters in diameter. Her caregiver reports that she accidentally touched the stove. The child appears withdrawn and has an older scar on her buttocks. You suspect physical abuse. Which of the following burn patterns is most suggestive of cigarette burns? A. Bilateral symmetric immersion burns on lower limbs. B. Patterned contact burns in the shape of a spoon. C. Deep, discrete circular burns, 8 to 12 millimeters in diameter. D. Paired circular burn, 0.5 centimeter in diameter and 5 cm apart. E. Superficial linear burns over the back and shoulder.
Good. So we must also learn, cigarette burns and how it presents as well in a child, right? If there is abuse, and the correct answer will therefore be C. Deep, discrete circular burns, which are 8 to 12 millimeters in diameter. So look at the size of the cigarette, the tip, which has the fire. Just look at the size, and that can give you a very clear indication. So these are classic for cigarette burns. They are well demarcated, they are circular, they are deep, because the adults will pick it, it's on the skin and it goes deep, right? And they are often multiple, and they will use it on various parts of the body. Okay. Doc, next question.
Yes. A 3-year-old boy is brought in for burn evaluation. His mother states he was playing and fell against the heater. On examination, you observe a partial thickness burn with a distinct rectangular grid pattern over his left thigh. He also has bruising on his upper arm. Which of the following features most strongly supports intentional injury? A. History of falling on a heater. B. Burn shape consistent with a household item. C. Partial thickness nature of the burn. D. Presence of bruises on the upper arm. E. Location on the thigh.
Good. So this one too, doctors, let's know your answers quickly, and then we move. And the correct answer is B. Burn shape consistent with a household item. Okay. So pattern burns like matching a heater or grate or iron are a red flag for abuse. Accidental injuries rarely have such distinctive shapes. So we are talking about non-accidental injuries. That is, case of abuse. Okay. So doctors, just wanting you to know as well that at MedCognito, various options exist. You can get access to our program for 1 month alone, especially for those who are going for the exam in April, for just 450 CAD. If you want to go for 6 months, it's only 420 CAD per month for 6 months. If you want to go for even 3 months alone, it's only $1,350. And this is how we teach, right? You do your mock exams, you have your personalized study portal, you come for classes 14 times a month. Every month we conduct 14 classes, right? And even the previous classes which were done, which you did not have access to, as in if you were not registered at the time, you still get access to replay it. And if you want to pay one time, it's only 2,199 CAD, one time payment for 6 months access. And then we move. Okay. So, management of child abuse. Now, Dr. Yosuti, we are bringing the whole game to an end. So please read this case for us and then we move.
Yeah. A 2-year-old girl is brought to the emergency department with second-degree burns on her buttocks and lower back. The caregiver states that the child accidentally sat on a heating pad for a few seconds. You observe that the burn shape has a sharp line of demarcation and appears symmetrical. The child appears withdrawn. What is the most appropriate next step in management? A. Interview the child alone to gather more history. B. Treat the burns and discharge the patient with caregiver instruction. C. Call the police to arrest the caregiver immediately. D. Report to child and family services and request an emergency assessment. E. Refer to dermatology for evaluation of burn depths.
Doc, thank you. So what's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? So some are going for B, some are going for D, some are also going for A. And the correct answer is D. You want to report to Child and Family Services and request an emergency assessment. Okay, so D is the correct answer because this child's injury pattern, the child's injury pattern and inconsistent history raise suspicion for intentional burns, and it's a red flag. Reporting to Child Protection Services is mandatory. Usually, you don't report to police, you report to Child Protection Services in such cases, and an emergency visit is wanted due to the immediate risk. All right. You will realize that when we get deeper, if the child is very young, it is encouraged that you let someone with a specialization in interviewing children do that. There is that clause, and I'll show you. And treat the burns and discharge the patient. Remember, we said that this increases the risk of being abused again by 33%. And call the police to arrest the caregiver immediately. No, that's not your duty, right? And refer to dermatology for evaluation of burn depth. Well, that can be done later, but this child needs immediate assessment and management. Okay, so that is why D is correct. So, management of child abuse. I always use this acronym SAFE. 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 So, SAFE is secure immediate medical care. That is why in this child, we're going to do our best to deal with the emergency before we do any other thing. Number 2, sorry, avoid asking the child for abuse details, especially if you don't have that training to do like abuse interviews in children. Avoid asking the child for abuse details. F stands for flag and report to Child Protection Services. So yeah, so there's a place. Somebody is asking a question here. I'll show you the question. The person says, Dr. Bonnie, is there a place to interview the child? There's a place, but usually when it comes to the details of the abuse, you want to leave it with those who have specialization in doing that. Okay. It's the same thing for like even females who have gone through some form of sexual abuse. Not even females alone, even males who have gone through some form of sexual abuse, right? Usually we have what we call a sexual abuse nurse who we invite to come in, and they do detailed history. They take pictures, and it's under very strict, very strict guidelines. So you don't want to just go in, maybe re-abuse the child emotionally while you're trying to get your history. So it is better if you have a situation like that to get somebody who has a specialization or who has been specially trained to interview abused children. Okay, and engage social worker and ensure follow-up. So the S, when I say do not take an abuse history from a young child, what I mean is never ask a young child to describe the abuse. This must be done by trained professionals. For example, child protection workers or forensic interviewers. Okay, your role is to assess medical and physical signs, not to conduct investigations. Doctors, please, is that clear? Dr. Curiosity, we cool? Good. Okay.
Yeah.
Next one. Report all suspicions to CAS. In Canada, report to Child and Family Services. It is mandatory. If you suspect abuse, not even if you are sure, you must report. Just by suspecting it, just report it. If it comes out that there's no abuse, that's fine. You as a doctor, you don't have anything, nothing will be done to you. But if you suspect abuse, please report it. And report or request an emergency visit if the child is in immediate danger or there's a sibling who is at risk. Now, what we have to understand as clinicians is that failing to report can lead to professional disciplinary action by the college and, by the boards which are involved in all this. So please, even if you suspect abuse, report it. Okay. Next one. If the child is injured or unwell, you want to hospitalize the child for treatment and full medical evaluation. Prioritize stabilizing injuries and ruling out life-threatening trauma, and ensure you document very well, accurately, and completely. Document what was seen, not what was suspected. Just document what you saw. Okay. And then last but not the least, arrange a consultation from social worker. So contact the hospital social work early. The social worker will help to assess the family environment, the stresses, the protective factors, and they'll coordinate with the child welfare, and they ensure safe discharge and community follow-up. Because there's only so much you can do, and if you don't involve social work, that can be a big problem. So doctors, thank you very much. We've done 1 hour 43 minutes of class today, and tonight you have a rheumatology class. I'll be announcing the date for the med drill. It should be this week. I'm thinking, could it be Tuesday? Because on Tuesday, those who are also taking the NACOSKI, that's when they have a class. And usually we have some people taking NACOSKI and Q1 class with us, and they go like, Bonnie, we also want to participate in the Q1 class. So you know what? I don't know what to do, but we'll do something. Okay. And so, doctors, tonight there's a rheumatology class, and then on Wednesday there's a Q1 mock exams. For those who are also going for the NACOSKI, very soon, if you want to do some mock exams with us, you will have the opportunity to do a one-on-one mock exams with us as well. So please watch your emails, watch your WhatsApp, and if you're not in our WhatsApp group, I'll say that this is the best time to make sure you join our WhatsApp group as well. Dr. Oyasoti, thank you very much for joining us today. I really appreciate it. I really wish that you can join us every week and help us, to go through these cases. Because when I'm here, I feel lonely, and actually I want to get other people to join me. So, doctor, thank you very much. I'll allow you to get some rest because tonight you have a rheumatology class. By the way, Doc, how is everything going? Class is going well? How is everything going with MedCognito? Yeah. Maybe. I don't know whether he heard my question. So, doctors, yeah, we'll just keep it there, and then we'll meet in class tonight. Reach out to me, okay? +1 306 891 5649. +1 306 891 5649. Thank you very much. We'll meet in class, and all the best. You can reach out to me. Thank you. Good night. Bye-bye. Bye-bye. Bye-bye.